Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of osteogenesis imperfecta, also known as brittle bone disease. This is a critical topic for any pediatric physician, covering diagnosis, classification, pathophysiology, investigations, medical and surgical management, complications, and differential diagnosis. We have 14 carefully designed clinical cases to walk through together. Let us begin. Case 1. A 4-year-old boy is brought to clinic with a history of multiple fractures involving the femur and forearm, occurring after minor falls since he began walking. His parents report no significant trauma preceding the first fracture. Developmental milestones are normal. On examination, his sclerae appear distinctly blue. A maternal uncle is noted to have a similar eye finding. Which type of osteogenesis imperfecta does this presentation most likely represent? Option A, osteogenesis imperfecta type 1. Option B, osteogenesis imperfecta type 2. Option C, osteogenesis imperfecta type 3. Option D, osteogenesis imperfecta type 4. The correct answer is option A, type 1 osteogenesis imperfecta. Type 1 is the mildest and most common form of osteogenesis imperfecta. Blue sclerae are the hallmark sign, caused by thinning of the scleral collagen, which reveals the underlying choroidal veins. Recurrent fractures from minimal trauma typically begin at walking age, and stature is normal or near normal due to preserved bone growth. Critically, this condition follows autosomal dominant inheritance. The maternal uncle with blue sclerae strongly supports the diagnosis and should always prompt a detailed family history. Case 2. A male newborn is delivered at 32 weeks gestation following an uncomplicated pregnancy. At birth, he is noted to have severely shortened and deformed limbs with visible angulation. Respiratory distress develops within the first hour of life, requiring immediate ventilatory support. On examination, markedly shortened upper and lower limbs, soft compressible skull with membranous calvarium, multiple palpable rib irregularities, and dark blue sclerae. Skeletal X-ray shows crumpled accordion-like long bones with multiple in utero fractures, beaded ribs, and severely undermineralized skeleton. Which osteogenesis imperfecta type does this presentation most likely represent? Option A, osteogenesis imperfecta type 1, mild non-deforming. Option B, osteogenesis imperfecta type 3, progressively deforming severe. Option C, osteogenesis imperfecta type 4, moderate severity normal sclerae. Option D, osteogenesis imperfecta type 2, perinatal lethal form. The correct answer is option D, type 2 osteogenesis imperfecta, the perinatal lethal form. Type 2 is the most severe and lethal form, usually fatal perinatally due to respiratory failure from thoracic insufficiency. It is caused by dominant negative glycine substitutions in the COL1A1 or COL1A2 genes. The classic radiographic findings are crumpled telescoped accordion-long bones, beaded ribs from multiple healed rib fractures, severe osteopenia with very thin cortices, and compressed vertebral bodies. An important clinical pearl, prenatal ultrasound after 14 to 16 weeks may detect shortened fractured limbs and a poorly mineralized skull, enabling early counseling for the family. Case 3. A 6-month-old infant boy presents to the emergency department after his mother noticed swelling of his right arm following routine diaper changing. History reveals multiple fractures detected on skeletal survey, no significant trauma or rough handling reported, and mother denies any history of falls. On examination, short stature for age, noticeable bluish tint to the whites of the eyes, mild looseness of joints on passive movement, and no bruising or soft tissue injuries suggestive of abuse. Investigations show skeletal survey with multiple fractures in various stages of healing, serum calcium and phosphate within normal limits, and no metaphyseal corner fractures. What is the most important next step in evaluating this patient? Option A, report suspected child abuse to Child Protective Services. Option B, order serum alkaline phosphatase and parathyroid hormone levels. Option C, assess for blue sclerae and joint laxity. Option D, initiate high-dose calcium and vitamin D supplementation. The correct answer is option C, assess for blue sclerae and joint laxity. In this infant with unexplained fractures, blue sclerae and joint hypermobility are the key physical examination findings that point toward osteogenesis imperfecta rather than child abuse. Blue sclerae result from thinning of the sclera, revealing the underlying choroidal veins and giving a characteristic blue-gray hue. Joint hypermobility results from the generalized connective tissue defect in osteogenesis imperfecta, affecting collagen throughout the body, not just bone. These findings help distinguish osteogenesis imperfecta from child abuse, which shows no connective tissue signs, and from rickets, which has a different radiographic and laboratory profile. Remember the clinical tip. The SPUTIV-MOR checklist can help systematically exclude physical child abuse in cases of unexplained fractures. Case 4. A 9-year-old boy has a history of recurrent long bone fractures since early childhood and progressive hearing difficulty noted over the past 2 years, with no significant trauma preceding fractures. On examination, sclerae appear white with normal color, teeth are discolored and translucent, and mild bowing of long bones is noted on inspection. Investigations reveal audiometry confirming conductive hearing loss, radiographs showing multiple healed fractures, and mild bowing of long bones. What is the most important next step in evaluating this patient? Option A. Diagnose as Ehlers-Danlos syndrome. Option B. Evaluate for dentinogenesis imperfecta and hearing loss. Option C. Order a computed tomography scan of temporal bones. Option D. Prescribe hearing aids and refer to ear, nose, and throat specialist. The correct answer is option B. Evaluate for dentinogenesis imperfecta and hearing loss. The combination of recurrent fractures, hearing loss, and discolored translucent teeth are hallmark non-skeletal features of osteogenesis imperfecta. These findings occur even when sclerae are white, as in types 3 and 4. Hearing loss in osteogenesis imperfecta results from abnormal ossicles, with conductive type being the most common. Dentinogenesis imperfecta causes amber or gray discoloration, chipping, and early wear of teeth. This is a critical clinical pearl. In osteogenesis imperfecta types 3 and 4, absence of blue sclerae does not rule out the diagnosis. Always look for dental and auditory clues when evaluating a child with recurrent fractures. Case 5. A 3-year-old boy presents with multiple fractures and blue sclerae. Genetic testing reveals a heterozygous mutation in the COL1A1 gene, resulting in a glycine substitution at position 748. Histopathology shows increased osteoid and impaired mineralization. Which of the following best describes the primary effect of this mutation on collagen? Option A. Quantitative reduction in type 1 collagen. Option B. Overmodification of collagen chains. Option C. Dominant negative effect on collagen folding. Option D. Disruption of post-translational processing. The correct answer is option C. Dominant negative effect on collagen folding. Glycine occupies every third position in the collagen triple helix in a glycine XY repeat pattern. Its tiny size allows tight triple helix packing. A bulkier amino acid substitution physically disrupts this coiling. The dominant negative effect means the abnormal chain poisons the entire collagen molecule. Even normal chains assembled alongside it are rendered dysfunctional, resulting in structurally defective collagen and bone fragility. Why are the other options wrong? Option A, quantitative reduction, is seen in nonsense or frameshift mutations causing haploinsufficiency, not glycine substitutions. Option B, overmodification, is a secondary consequence, not the primary mechanism. Option D, post-translational processing defects, is seen in recessive osteogenesis imperfecta with CRTAP or P3H1 mutations. Case 6. A 7-year-old girl is referred for evaluation of recurrent low trauma fractures. She has sustained 4 fractures since age 2, all following minor falls. Her stature is normal for age. On examination, she has blue sclerae bilaterally and mild joint hypermobility. Her teeth appear normal. Her father also has blue sclerae and a history of childhood fractures. Genetic testing reveals a heterozygous nonsense mutation in COL1A1, predicted to cause premature stop codon and messenger RNA degradation by a nonsense-mediated decay. Which of the following best describes the primary molecular mechanism responsible for this patient's condition? Option A, quantitative reduction in type 1 collagen due to haploinsufficiency. Option B, structural defect from glycine substitution causing dominant negative effect. Option C, abnormal bone mineralization due to osteoblast dysfunction. Option D, vitamin D deficiency leading to impaired collagen cross-linking. The correct answer is option A, quantitative reduction in type 1 collagen due to haploinsufficiency. Type 1 osteogenesis imperfecta results from haploinsufficiency. One COL1A1 allele is non-functional due to a nonsense or frameshift mutation. The messenger RNA undergoes nonsense-mediated decay, and as a result, only approximately 50% of normal type 1 collagen is produced. Crucially, the collagen structure is normal, it is just reduced in quantity, leading to mild to moderate bone fragility. This contrasts with types 2, 3, and 4 where glycine substitutions cause a dominant negative effect producing structurally defective collagen. Remember the key table. Type 1 is haploinsufficiency with mild severity, while types 2, 3, and 4 involve glycine substitutions with dominant negative mechanisms and increasing severity. Case 7. A 2-year-old girl is referred for evaluation of short stature and recurrent fractures. Skeletal survey reveals generalized osteopenia, thin cortices of long bones, multiple Wormian bones on skull X-ray, and beaded rib appearance. Serum calcium, phosphate, and vitamin D levels are within normal limits. Alkaline phosphatase is mildly elevated. No signs of malignancy. What is the most appropriate next diagnostic step? Option A. Diagnose as rickets and start vitamin D therapy. Option B. Order genetic testing for COL1A1 and COL1A2 mutations. Option C. Perform fibroblast culture and collagen analysis. Option D. Initiate bisphosphonate therapy immediately. The correct answer is Option C. Perform fibroblast culture and collagen analysis. This is the gold standard diagnostic test for osteogenesis imperfecta. Fibroblast culture evaluates both the quantity and quality of type 1 collagen produced by the patient's own cells. It detects abnormalities in collagen thermal stability, synthesis rate, and electrophoretic migration patterns. Biochemical analysis then guides subsequent genetic testing for COL1A1 and COL1A2 mutations. Why are the other options wrong? Option A is incorrect because the radiographic findings of Wormian bones and beaded ribs are inconsistent with rickets. Option B, genetic testing alone, is useful but secondary to biochemical confirmation in clinical practice. Option D, bisphosphonate therapy, is a treatment step and is premature without a confirmed diagnosis. Case 8. A 28-year-old woman, gravida 2 para 1, at 18 weeks of gestation, is referred to a high-risk obstetrics clinic. She has a known diagnosis of osteogenesis imperfecta type 3, and her first child was also affected. She is concerned about the risk to the current fetus. Prenatal ultrasound at 14 weeks showed shortened bowed femurs and suspected decreased echogenicity of long bones. Fetal movements are noted to be reduced. Family history is significant for multiple affected members across 2 generations. What is the most appropriate next step in the prenatal evaluation of this fetus? Option A. Perform routine prenatal screening only and reassure the mother. Option B. Proceed with amniocentesis alone for chromosomal karyotyping. Option C. Order maternal serum marker panel as the primary diagnostic tool. Option D. Perform detailed fetal ultrasound and targeted genetic testing for osteogenesis imperfecta-related gene mutations. The correct answer is Option D. Perform detailed fetal ultrasound and targeted genetic testing. In severe osteogenesis imperfecta, particularly types 2 and 3, prenatal diagnosis is possible due to striking skeletal abnormalities visible on fetal ultrasound. Key ultrasound findings include shortened bowed long bones, especially the femur and humerus, in utero fractures visible as angulation or callus formation, decreased fetal movements due to pain and fragility, poorly mineralized skull compressible on ultrasound probe pressure, and beaded ribs from multiple healing rib fractures. Targeted genetic testing for COL1A1 and COL1A2 sequencing is performed after ultrasound findings raise suspicion, confirming the molecular diagnosis and guiding counseling. An important alert: first trimester ultrasound showing short femur length combined with a positive family history warrants urgent genetic referral. Case 9. A 7-year-old girl is referred to your clinic with a known diagnosis of osteogenesis imperfecta type 3. She has sustained 6 long bone fractures in the past 2 years. Fractures occur after minimal or no trauma, and she is currently wheelchair dependent due to lower limb bowing. On examination, short stature for age, triangular facies, mild scoliosis noted, and no acute fracture at presentation. Investigations: dual energy X-ray absorptiometry, skin showing markedly low bone mineral density with a Z-score of -4.2, serum calcium, phosphate, and vitamin D all within normal limits, and COL1A1 mutation confirmed on genetic testing. What is the most appropriate pharmacological treatment to reduce fracture frequency in this child? Option A. Intravenous bisphosphonates such as pamidronate or zoledronic acid. Option B. Oral calcium supplementation alone. Option C. Recombinant growth hormone therapy. Option D. Intranasal calcitonin spray. The correct answer is Option A. Intravenous bisphosphonate therapy. Intravenous bisphosphonates, particularly pamidronate and zoledronic acid, are the gold standard pharmacological treatment for moderate to severe osteogenesis imperfecta in children. They work by inhibiting osteoclast-mediated bone resorption increasing bone mineral density and significantly reducing vertebral and long bone fracture rates. Pamidronate is given every 3 to 4 months and can be used at any age. Zoledronic acid is given every 6 months and is used in children older than 1 year. Both agents improve mobility, reduce bone pain, and can improve bone mineral density by 30 to 50%. Oral calcium alone is insufficient. Growth hormone has limited benefit for primary bone fragility. Calcitonin is not a recommended therapy in current guidelines for osteogenesis imperfecta. Case 10. A 5-year-old boy with a known diagnosis of osteogenesis imperfecta type 3 presents to the orthopedic clinic. He has severe progressive bowing of both lower limbs and has been wheelchair dependent for the past 8 months. Despite consistent conservative care, including physical therapy and nutritional support, he continues to sustain recurrent fractures. His parents are concerned about his ability to ever walk independently. What is the most appropriate next step in his management? Option A. Initiate growth hormone therapy. Option B. Perform intramedullary rod placement for long bones. Option C. Start oral alendronate. Option D. Refer to physical therapy for gait training. The correct answer is Option B. Perform intramedullary rod placement for long bones. In children with osteogenesis imperfecta type 3 presenting with severe long bone bowing and recurrent fractures, intramedullary rod placement is the cornerstone of surgical management. Rods provide internal stabilization, correct deformity, and dramatically reduce future fracture risk. The preferred device is the Fassier-Duval telescoping rod, designed to elongate with bone growth, ideal for growing children because it is inserted through the epiphysis and eliminates the need for reoperation as the child grows. It also corrects angular deformity while stabilizing the shaft of the bone. Growth hormone therapy has limited benefit for primary bone fragility in osteogenesis imperfecta. Oral alendronate is less effective than intravenous bisphosphonates in severe disease. Physical therapy alone is insufficient without structural correction in severe deformity. Case 11. A 7-year-old girl with osteogenesis imperfecta type 3 recently underwent bilateral intramedullary rod placement for progressive femoral bowing. She is now 4 weeks post-operative, non-weight-bearing, with healing surgical sites. She has a history of multiple prior fractures, mild scoliosis, and generalized muscle weakness. Her parents ask about the best approach to optimize her long-term mobility and functional independence. What is the most appropriate next step to optimize this patient's long-term mobility and function? Option A. Strict bed rest until complete bone healing. Option B. Encourage high-impact sports for muscle strengthening. Option C. Bracing alone without active physical therapy. Option D. Multidisciplinary rehabilitation and physical therapy. The correct answer is Option D. Multidisciplinary rehabilitation and physical therapy. In osteogenesis imperfecta, bones are fragile, but muscles, joints, and function can be strengthened safely with the right approach. Multidisciplinary rehabilitation reduces fracture risk, improves mobility, builds muscle support around fragile bones, and dramatically enhances quality of life. Physical therapy strengthens muscles around bones, improves posture and gait, and reduces fracture frequency. Occupational therapy focuses on adaptive daily living skills, safe movement strategies, and assistive device training. Aquatic therapy is a low-impact, joint-friendly exercise that builds strength without fracture risk. The multidisciplinary team approach involves orthopedics, rehabilitation, genetics, endocrinology, and psychology working together in a coordinated, patient-centered model. Physical and occupational therapy are not optional in osteogenesis imperfecta management. They are essential pillars. Case 12. A 16-year-old boy with osteogenesis imperfecta type 3 presents with sudden onset of severe headache, neck stiffness, and dizziness. Magnetic resonance imaging reveals basilar invagination with brainstem compression. The patient reports worsening symptoms over 48 hours. Neurological examination shows mild ataxia. No history of recent trauma or infection. Which is the most appropriate immediate management? Option A. Initiate anticonvulsants for seizure prophylaxis. Option B. Perform urgent neurosurgical decompression. Option C. Order computed tomography angiography to assess vascular anomalies. Option D. Start corticosteroids for inflammation. The correct answer is Option B. Perform urgent neurosurgical decompression. Basilar invagination is a severe, potentially life-threatening complication of osteogenesis imperfecta type 3 caused by progressive softening of the skull base, a condition known as platybasia. The odontoid process migrates upward, compressing the brainstem and upper cervical cord. This presents with headache, neck stiffness, dizziness, and progressive myelopathy. Respiratory compromise may occur in severe cases. Urgent neurosurgical decompression is required to prevent irreversible neurological damage. Annual magnetic resonance imaging surveillance is recommended in osteogenesis imperfecta type 3 patients for early detection. Anticonvulsants are not indicated because compression, not seizure activity, is the mechanism. Computed tomography angiography is not the priority since magnetic resonance imaging already confirms the structural compression. Corticosteroids are not indicated because this is a structural problem requiring decompression, not an inflammatory etiology. Case 13. A 14-year-old girl with known osteogenesis imperfecta type 3 has been followed in a multidisciplinary clinic since infancy. She is wheelchair-dependent due to severe long bone deformities and has a history of multiple fractures treated with intramedullary rods. She is currently on intravenous bisphosphonate therapy. She has no current cardiac or respiratory complaints, but her physician is reviewing her long-term monitoring plan. Which of the following is the most appropriate component of her long-term systemic monitoring? Option A, annual electroencephalogram monitoring. Option B, renal ultrasound every 6 months. Option C, annual echocardiography. Option D, monthly liver enzyme monitoring. The correct answer is option C, annual echocardiography to monitor aortic root diameter. Osteogenesis imperfecta involves a systemic defect in type 1 collagen, which is a critical structural component of cardiovascular tissues, including the aortic wall and cardiac valves. Aortic root dilation occurs due to collagen-deficient vessel walls and may lead to aortic regurgitation or dissection if unmonitored. Valvular regurgitation, particularly mitral and aortic, results from myxomatous degeneration of collagen-deficient valve leaflets. Annual echocardiography is the recommended surveillance tool to track aortic root diameter and valvular function, enabling timely intervention before complications arise. A vital clinical pearl, cardiovascular complications are often clinically silent in early stages. Routine echocardiographic screening should begin at diagnosis and continue annually regardless of symptoms. Case 14. A 2-year-old girl is brought to the emergency department by her parents following her third long bone fracture in 8 months. Parents report the fractures occurred from minor household falls. On examination, she has mildly blue-tinted sclerae, normal developmental milestones, and no bruising or retinal hemorrhages. There is no witnessed trauma preceding the most recent fracture. Family history is notable for a paternal cousin with frequent childhood fractures. Radiographs show osteopenia and gracile long bones. The child appears well-nourished and well-cared for. What is the most appropriate next step to clarify the diagnosis? Option A, skeletal survey and family history. Option B, immediate child protective services report. Option C, brain magnetic resonance imaging. Option D, coagulation profile. The correct answer is option A, skeletal survey and detailed family history for bone fragility. Differentiating osteogenesis imperfecta from child abuse is one of the most critical and sensitive clinical challenges in pediatrics. Key osteogenesis imperfecta clues include family history of fractures, blue sclerae, Osteogenesis imperfecta, Wormian bones, and fractures from minimal or no trauma. Key child abuse clues include inconsistent history, posterior rib fractures, metaphyseal corner fractures, retinal hemorrhages, and bruising in non-mobile infants. Skeletal survey reveals fracture patterns, healing stages, and bone quality and is the essential first step. Genetic testing for COL1A1 and COL1A2 confirms osteogenesis imperfecta when the clinical picture is ambiguous. An extremely important point, both diagnoses can coexist. Osteogenesis imperfecta does not exclude child abuse. Never dismiss abuse solely on the basis of an osteogenesis imperfecta diagnosis. Before we wrap up, we would like to invite you to join our Patreon community called Pediatric Case Review. This is your dedicated clinical learning hub where all our videos are organized by system. So whether you are studying musculoskeletal, cardiology, neurology, or any other specialty, you can access all related videos in one place without searching through multiple uploads. In addition, all presentation slides used in our videos are available as high-resolution images, so you can read, review, and practice all questions at your own pace. If you would like to know more about how to subscribe, simply comment below in this post, and we will message you directly with all the details. And that brings us to the end of today's lecture on osteogenesis imperfecta. We hope this comprehensive case-based review has sharpened your clinical skills and strengthened your diagnostic confidence when encountering children with recurrent fractures, bone fragility, or suspected connective tissue disorders. If you found this lecture valuable, Please follow the Pediatric Case Review channel for more informative presentations covering a wide range of pediatric musculoskeletal and systemic disorders. If you have any questions about today's cases or any pediatric topic, drop a comment below. We read every comment and do our best to respond. Stay updated, stay informed, and keep improving your clinical practice.